Okay, welcome. Welcome to Electrical Modalities. This is a basic introduction to electrical modalities. We will focus on some of the principles and concepts that surround what these modalities are and how they're used, and safety, precautions, contraindications, those kinds of things. This really won't include a description of specifics for use with various patients. Look for an additional WebEx that will include specific diagnoses and types of interventions that you can provide for those diagnoses utilizing electrical modalities. So if we're all ready, I'll go ahead and get started. So what is an electrical modality? Well, an electrical modality is any intervention which requires an electrical current to create or deliver. This can be by plugging the unit into a wall socket, or it can be utilizing a battery. They may or may not be thermal in nature, meaning generating heat. Not all of electrical modalities generate heat. Obviously, ultrasound is a unit that is designed to create a heating effect, but electrical stimulation for muscle contraction or TENS is not. So when utilizing electrical current, the current may or may not include the patient in creating the circuit. A circuit is a complete circle of electricity. Electricity flows from negative to positive. It has to have some conductor in order to make that connection between the two ends of the leads, in these cases with electrical stimulation. With, again, muscle contraction, E-stim for muscle contraction, or TENS, the electricity will come out of one pole of the channel. Usually every channel has two leads. The electricity will come out of one, pass through the electrode into the patient, return through the other lead. So that has the patient as part of the circuit. Ultrasound does not use the patient as part of the circuit. The electricity goes from the machine into the sound head, stimulates a crystal. Electricity then passes back through that sound head, back into the machine, and the patient only receives the vibration through ultrasound waves that occurs out of the sound head, but none of the electrical current. So if you ever have a patient who says, oh, I feel stinging or tingling or electricity coming from that, discontinue use of the machine and have it serviced because it may not be grounded correctly. If, on the other hand, you are using electrical stimulation through the sound head as part of a combination treatment where you're doing E-stim through the sound head, of course they should be feeling that, but you should also have another electrode placed somewhere on the patient so that the electricity can go through the sound head and into that electrode and back to the machine. So, also, electrical modalities, when we talk about them, they certainly should have a distinct effect on the patient. Electricity can always have an effect on people, sometimes positive, sometimes negative. Of course, we're looking for a positive effect. I say that because if we're not having a distinct and hopefully positive effect on the patient, we're either doing it wrong or it's not a valid modality for treatment of that individual. So one of the things we need to have is sort of a common language when we're talking about electrical modalities. What we usually refer to in our electrical modality usage will be ultrasound, certainly, and electrical stimulation. Well, electrical stimulation actually comes through in multiple types. Sometimes people refer to E-stim thinking about only muscle contraction, but really any delivery of current through electricity, through electrodes, to stimulate some sort of response is electrical stimulation. So the first one, transcutaneous electrical nerve stimulation, usually referred to as TENS, is to stimulate the nerve endings in order to elicit a decrease in pain. That is still electrical stimulation, and we're stimulating nerve endings. Of course, we have multiple other kinds. You have premodulated, we have Russian, high volt pulse current, there's interferential, and there's microcurrent. We will talk about each one of these individually. There's also diathermy. Diathermy is very similar to ultrasound. It can be more risky because it's actually the release of microwave radiation, very similar to the microwave in the kitchen that you have. So we do need to be careful with that one when other patients are around, because that's certainly not any modality you would ever deliver to somebody in range of the unit, which usually means in the room, who has, say, a pacemaker, because it can cause tremendous disruption. Now, this is not a typical type of unit that you'll find in all of our facilities, so I'm not really going to discuss that here. Any of the facilities that do have this, if you want more information, please just let me know, and I'll be happy to talk more about diathermy then. So getting back to having a common language, we do need to understand some basic terms that come along with electrical modalities. Not understanding these things restricts our ability to make the right adjustments, or it holds our clinical judgment back for not having the knowledge in order to make the correct assessments of the intervention, or certainly any kind of correct change to the waveforms and other things that we will absolutely talk about. So the first thing we need to talk about is current. And I did mention current before, because sometimes the patient is involved in the current, and sometimes they're not. But current basically is a flow of electricity. We describe it by convention as moving from positive to negative. But if you remember, just a couple of slides ago, I said that the flow actually is from negative to positive. That's because when they originally were doing experiments with electricity, they had not discovered really the makeup of the atom at that time. Niels Bohr had not drawn his famous picture of a hydrogen atom with a central nucleus and an electron flowing around it. So they didn't really know that electricity was dictated by a flow of electrons, because they hadn't discovered an electron yet. So they just noticed that there was an effect that they saw more typically on the negative or the positive, I can't remember now, actually the positive side, I believe, of the current. So they said, well, it must be something that's building up on the positive side, flowing to the negative side. Unfortunately, because that was so ingrained through science and explanation and description for so long, that's still the convention that's used. We do need to understand, though, that it is a flow of electrons from negative to positive, because sometimes that does dictate which electrodes we place where for certain types of E-stim, so that we are eliciting the correct response from the patient. Another term, waveform. Waveform is kind of what it sounds like. We're describing the shape of the wave of the electrical current. And when we talk about electrical current and waves, what we're describing there is a change possibly from positive to negative. If you do think about a wave in an ocean, very similar. As the wave rises, think about a horizontal line, and then the wave coming up above that line, moving into a positive polarity, reaching a crest, coming back down, maybe crossing that horizontal line, so going underneath it and developing more of a negative charge, and then returning back up to that horizontal line. So if we start at the horizontal line, go above it, cross it, go below it, come back to it, that's a single wave. Okay, so that's a wave, and its form is bipolar, because you have positive and negative, okay, and it may be symmetrical. The amount of positive is the same as the amount of negative. And we'll talk a little bit more about that later with different types of waveforms. So just to understand that, the waveform is the shape of the wave, intensity of the positive down to the intensity of the negative. Frequency. This is the number of pulses or cycles per second, usually described in hertz. To give you basic example, the electricity that comes out of your wall socket is actually in 60 hertz. So there's 60 cycles per second from the electricity coming from your wall socket. A lot of machines and technology that we have, including probably the computer that you're looking at right now, can't handle that kind of cycle of hertz, so they all have these power packs. Laptops, you always have actually what they refer to as the brick, which is that rectangular piece in your cord that converts that electricity to something that won't damage the machine. It's also why you can't use your hair dryer when you go traveling to foreign countries, because they're set up on different hertz for their electricity as it comes out, and it'll burn out your unit. So the next one is amplitude, and that basically is describing how high the current reaches at its most. So in other words, what's the peak of the amplitude of the wave? Now, that does get a little confusing because a lot of times in therapy, we will describe amplitude as the same as intensity. So just be aware of that. Technically speaking, amplitude is the maximum height or depth, you know, the top or the bottom, the maximum of that wave, but often with the machines, you'll see the amplitude being the intensity that you control as you turn the unit up to achieve the desired effect. Wave width is how long each pulse of current is on. So if you go back to frequency, you've got pulses per second. Each one of those pulses is measured in fractions of a second. A lot of times you'll see nanoseconds or microseconds for each pulse. So you think about a second is, you know, break a second into 100 units. And if you have a wave width, or say the frequency of your wave is 10, so 10 hertz, which would be 10 waves within a second. And if we said a second was divided up into 100 units, then each width would be 10. So each wave width is 10, and you have 10 waves in that cycle. So 10 times 10 is 100. Trying to do the math easy so I don't get lost. The rate is sometimes used interchangeably with the frequency. Just how quickly or how many times does that wave start and end. So you'll see rate typically more written in the unit that you're using, the electrical stim unit that you're using, versus frequency. Ramp can be important because ramp can help make the treatment more comfortable for your patient, but it also can decrease the amount of maximum time or the time that the maximum current is being delivered. So to explain that a little better, it's the pace at which the current takes to reach its peak intensity. So you can set the ramp for 1 second, 2 seconds, 3 seconds, depending upon your machine. And if you set it for 3 seconds, and if you think about an actual ramp, that's got a more gradual slope. So it's going to build up. It's going to take 3 seconds to build up to its maximum intensity that you have set it, the unit for. Where that becomes important is if you're doing, say, a muscle re-education program, and you have the unit coming on for 5 seconds and off for 5 seconds. If your ramp is 3 seconds, they've only reached peak intensity of that electrical stimulation for 2 seconds, because it takes the 3 seconds to get up to the highest intensity, and then 2 more seconds until it shuts off again. So keep that in mind. The slower you build it up, sometimes the more comfortable for your patient, but you're losing that peak intensity time. So just something to be aware of. Intensity is the peak level. That's directly what is set by the therapist. Important to keep in mind, though, that the intensity from one day to the next for the same exact treatment may never be the same. This is influenced by many, many factors. A lot of times I'll have patients say, okay, yesterday when you did this, I was on 15, so let's see if we can't get to 18 today. And I have to, let them know that that has absolutely nothing to do with the effectiveness of the treatment. If I didn't put the electrodes in the exact same spot, they're a little bit closer, a little bit further away, and we can talk about millimeters when it comes to that. The condition of the electrodes, if there's more, because we're going to get to the last one, impedance here, we're going to have to turn it up higher. If the patient is more or less hydrated that day, will make a difference as to the flow of electricity. So you may not need to turn it up as high the next time you do the treatment because the conditions are more favorable. You're using new electrodes because the other ones get so grungy you had to throw them out. So there are a lot of factors. The intensity is important only in the sense of, are you achieving what you're looking to achieve by the intervention? The number in and of itself is not important. Duration, amount of time for one cycle. So this is total treatment time when we talk about it, okay? So how long did you have the e-stim running? 15 minutes, 30 minutes, that's the duration. Now impedance, I mentioned it briefly. I want to talk a little bit more about it. Simply described as the resistance to the flow of current, but is extraordinarily important because the amount of impedance will dictate a lot of times whether there's comfort during the treatment, irritation, or even potentially skin burn, okay? The impedance is, again, the flow of resistance of, the resistance of flow of the current. It is affected, as I mentioned, about the condition of the electrodes. If there's a lot of dead skin cells, oils, anything like that, dust, whatever, because these electrodes are sticky, they pick up a lot of stuff. Even when you're careful with them, and you take them off the patient, you put them right back on the little plastic sleeve, they wear out. There's a sticky gel that's on the electrode that can dry out over time. It also will always pick up dead skin cells from the patient that you've applied them to. And this is why we use one set of electrodes for each individual patient. They are not interchangeable between people, okay? When they get like that and they lose a lot of that adherence, they don't stick as well, you can run them gently under some warm water, just lightly rubbing them to try to wash off some of that. Let it kind of air dry at that point, and you may revitalize them a little bit. That only works to a certain point, but if they're not really sticking, certainly if you feel like you need to take the electrode on, it's time to throw the electrode away and get a new pair, because that impedance, with that resistance to flow, you have to turn the intensity of the treatment up, and sometimes you have to turn it up so high that it actually causes irritation, which can cause skin damage. A lot of times, though, the patient may not feel a lot of difference coming through the electrode because the amount of current they're receiving doesn't feel different, even though you're turning it way up. But what's happening is you're creating some real surface, superficial dermal irritation because of that flow resistance. Keep in mind, people's natural skin, derm, is resistant to the flow of electricity. It takes a certain amount to overcome that resistance in the first place. That's why you can't just turn the unit up to 1 and expect people to feel it. But again, it's influenced by how hydrated they are. Did they, it sounds terrible, but did they bathe that day? And did they wash the area? Did they put a lot of lotion on? A lot of lotions are very resistant to the flow of electricity or create a barrier for the flow of electricity. So keep all of that in mind. If you're noticing that you're kind of turning the unit up and it's kind of a little bit excessive from where you would naturally have it, remember the number doesn't have to always match, but you're normally running at, say, 12, and now you're turning it up to 30, you go, well, okay, wait a minute, maybe something's not quite right. I usually do recommend cleaning off the area that you're providing the electricity, the e-stim to. I don't always recommend rubbing it down with an alcohol wipe because sometimes that can decrease the impedance so much that too much current gets passed through, okay? So I don't always like using something irritating like an alcohol swab, but I may use just a little soap and water and just kind of wash the area if it feels particularly greasy from maybe having too much lotion on. But then, sometimes it's just a matter of lightly washing it with just a little bit of water on a towel, just to kind of clean it off a little bit, and then dry it a little bit, and then put the electrodes on. So hopefully that's clear. So now we're going to move into looking at the different types of machines we have in the clinics. These are the two most common that I see in the clinic. The one on the left, the Transport 2, that's a little bit, well, I shouldn't say it's a newer machine. It's one that we've recently purchased a number of for a lot of our independent living facilities, so that's the one that they may see more commonly. I've seen the Vector Genesis a lot in our skilled nursing facilities. It's not a hard and fast rule. It's not like one can't have the other, and just those are the ones, that's the way I see it laid out a lot of times. These basically are, well, they're certainly the same company, the Chattanooga group that makes it, and they are basically the same units, except the Vector Genesis has a little bit more bells and whistles in it. There's actually a library of information in it, and there are some additional waveforms that it has that the Transport 2 doesn't have. And that being said, I like the Transport 2. It's a little bit lighter machine. It's a little bit, I'd almost say more user-friendly because it's simplified, and it does absolutely everything that you would need it to do, especially in the setting that we see it in right now. It's a fine machine. It works very well, and it has all the waveforms that you need in order to treat just about anything you're going to see. So let's talk about electrical stimulation. The different types of electrical stimulation, I'd listed them for you before. We're going to start with interferential current, IFC. It's a traditional 4-pole electrical stimulation. What that means is you have to have 2 channels in order to deliver this type of intervention. Both machines have 2 channels. Each channel has 2 leads, okay? So you're looking at 4 poles. It's a medium frequency waveform, so kind of the middle of the range of how frequently that's coming on. If you remember, we talked about frequency, how many cycles per second is going on. Current is distributed through 2 channels, like I said, so you have 4 electrodes. The current must cross, okay? So when you apply this to an individual, you're looking at creating an X for your leads. So channel 1 will have 2 leads. You place those down. And channel 2 will have 2 leads. And if you draw an imaginary line between the 2 leads of channel 1 and the 2 leads of channel 2, they should form an X or a T, depending upon your orientation. That's important because the current will only deliver the intended effect where those 2 points cross. So drawing that imaginary line is important because in this case, X marks the spot. You need to put the intended treatment area in the crosshairs in that sense. So the 2 currents interfere with each other, and that's why they call it interferential current. What that basically means is there's a carrier wave. And that carrier wave is extremely high in its frequency. We're talking 3,000 to 4,000 hertz. So think about, you got 3,000 to 4,000 individual cycles in a second. Okay, so it's a very, very high frequency. But that's the carrier wave. So you may have the medium frequency waveform. So it's putting that medium frequency waveform, so it's putting the wave that's the treatment wave onto this carrier wave. And I've always kind of described it as, one side is going at 3,000 hertz, the other channel is going at 3,001 hertz. Now, if you can remember back to some basic physics that you may have taken in high school or college, when two waves meet, if the two waves meet at the same time at a peak to the top of the waves, it will double the amplitude. If two waves meet, one at a peak and one at a trough, so in other words, one's up and one's down, they cancel each other out. So you've got these two carrier waves crossing in the center point at and being slightly off, okay, so that the wave that we're trying to use to create the electrical stimulation then is created by this occasional doubling the wave, sometimes canceling the wave. So, and it's kind of really hard to explain, I suppose, and it may not be very clear, but just understand the fact that because it's being carried by this carrier wave and it's often being delivered where those 2 points cross, needs to go over the intended target, okay? Premodulated, this is a traditional two-pole, and it says interferential current. Just described that way because it delivers the same type of current, but only between two poles. So you surround, or basically monkey in the middle, you know, electrode on either side of the intended target that you're treating, and the current will go between those two electrodes. Keep in mind that the closer you have the electrodes, the more current is going to go through the superficial dermal layers versus further apart where it will actually arc downward beneath the dermal layers and into the muscle tissue. So you should really never have the electrodes closer than the width of one electrode. You know, so if you're using a 2x2 electrode, you should have your electrodes at least 2 inches apart, but you can certainly go further apart than that. Pushing them further apart, you have to turn your intensity up so that the current can overcome all the resistance of all the body layers in order to get to the other electrode. So also be a little cognizant of that so you don't put it so far away that you have to turn the unit up so far that there's irritation on the surface underneath the electrodes. Okay, so this is all just a matter of balance. This is done with a single channel, so you have two electrodes. You can do premodulated on one channel on one part of the body and premodulated on another channel on another part of the body. So you may do bilateral knees, you know, channel 1 on the right knee, channel 2 on the left knee. You can do a knee and an ankle. You can do, you know, an ankle and an elbow. You know, you get the idea. The current intensity is modulated, which is nice. That's why it says premodulated. It'll increase and decrease and widen and narrow kind of in a predetermined way. And what that does is it maintains the same amount of current provided to the individual, but changing the way that it's being delivered. So in other words, as it goes, the intensity increases, the wave width decreases. And then when the wave decreases in intensity, the wave width increases. So if you add up the amount of current that's being delivered in those two different things, it comes out to be about the same. But by modulating it, the body can adapt to it. And so you can deliver the treatment and intention more consistently without having to go over and fiddle with the machine. Okay. High volt pulse current. This is a very brief pulse duration with two distinct peaks delivered at high voltage. Don't let the high voltage part scare you. I mean, high voltage in comparison to what we're doing versus high voltage compared to touching the circuit breaker box in your house, okay? This is high voltage in electrical stimulation delivery. It's also not always the voltage that's the problem. You know, you hear this kind of, it's not the volts, it's the amps. Amps are very disruptive to heart rhythm and things like that. So this is a very safe current. It's also, because it's monophasic and delivered in this manner, it decreases the skin resistance, that impedance, and so it can actually make the treatment a lot more comfortable for the patient. So that's why this high volt pulse current is very good. the other thing about high volt pulse current is that it is delivered either positively or negatively. Now, sometimes that won't matter if you're just looking to get muscle contraction. You can just set it up, and it's going to flow from the negative to the positive, and it'll work. You don't have to worry about, wait, do I need to put this electrode here or this electrode there? Where that really comes into play, where it's really kind of important, is with wound care. High volt pulse current works very well for wound care because when wounds are healing, they require different nutrients and different supplies. And some of those things are positive, some of those things are negative. Opposites attract, okay? Happens especially in electricity, not just in relationships. So if you put the positive over a wound, you're going to attract a lot of negatively charged molecules and ions to that area that the body will need in order to heal that wound. You put the positive over the wound, the negative over the wound, you're going to attract a lot of positive, okay? The body needs both. So this gets into a little bit of, well, how do you know which one to put on? Typically, with the wound in the initial stages of healing, you want to use the negative electrode initially. So we usually put the negative, and we can talk more about wound care maybe on another WebEx, or if you have questions specifically, you can contact me. We'll put the negative over the wound for the first week on a daily treatment. And then after that, we'll switch between negative and positive about every 3 days. So 3 days of positive, 3 days of negative, back and forth until the wound has healed. So that's the high volt pulse current. Russian stim, which I always think is slightly amusing because I believe it gets its name not only from the original designer or the guy who talked a lot about it, Coates there, but also because the Russians tried to use electrostimulation to enhance the performance of their athletes before in the Olympics, and it was back in the 70s, by having the muscle contraction from the machine come on when they're exercising, trying to actually make their athletes stronger, and it didn't work. And the reason for that is artificial stimulation of a muscle will only work to a certain point. After that, it's the body's normal function that will make the muscle contract more effectively, efficiently, and develop more strength. So Russian stim is described as a sinusoidal wave, and I don't know if you remember your high school trigonometry, but sinusoidal refers to the fact that it is positive and negative. It undulates, in a sense. It looks like the waves in the ocean. There are peaks and there are troughs. So it goes above that horizontal line, it goes below that horizontal line. It's very smooth, up and down kind of look to it. It can be delivered in bursts or a series of pulses, and it's claimed by the author that it'll produce maximal muscle strengthening effects without significant discomfort for the patient. So there are different waveforms that you can use to create muscle contraction. The claim is that this one is more comfortable. My personal opinion on that, and I'll always try to stress when something is my personal opinion, is that sometimes it is more comfortable and sometimes it isn't. It really depends upon your patient and their tolerance and their comfort level overall. So with all of these, it's a matter of try it. If it doesn't work, try something else. It doesn't mean they won't respond to e-stim. It means they may not respond to that form of e-stim. That's why it's important to understand the waveform differences and that there are differences. Not that you have to be able to memorize what the waveforms are, but just really an understanding that they are different and the body will respond differently to different waveforms. Now, TENS, symmetrical biphasic. What you'll see in the title of this particular slide is that you have vector in parentheses. That means that the remainder of these descriptors for these different types of waveforms, these waveforms you'll only find on the vector genesis. You won't find them on the transport 2. Does that mean you can't do TENS with the transport 2? You can do a form of TENS because the The premodulated setting will actually do the same type of treatment as TENS. TENS it's not really a brand name, but it's almost reached that point. It's like saying a Kleenex when you're talking about tissues. The TENS effect can be delivered through different waveforms, and we'll talk about that in a minute. But in this case, when you have the symmetrical biphasic, it means that it's two phases, positive and negative, and those two parts are symmetrical in size and shape. So it's a short pulse duration capable of strong stimulation of nerve fibers in the skin and muscle. That's an interesting distinction because I said at the very beginning, TENS stimulates the nerve. When we do things like Russian stim, what we're stimulating is the neuromuscular junction. So it's actually where the nerve is attaching to the muscle. It stimulates that site. It doesn't stimulate the nerve per se. TENS directly stimulates the nerve. And what we're looking at with this one, and everybody's kind of familiar with the idea of TENS, but it's the gate theory of pain, where if we can stimulate the large, fast, afferent nerve fibers, they will basically race up to the brainstem and into the thalamus and release a lot of neurotransmitter at that point, at that synaptic junction, so that the slow afferent nerve fibers that are carrying the sensation of pain from the site, when they get up there and they release their neurotransmitter, which is slightly different, the receptor sites are clogged up with this other neurotransmitter, and so it can't deliver that same intensity of pain, okay? So I go through that long explanation because you can't put TENS on and expect pain to go away, okay? We're not blocking pain. What we're doing is reducing it because now the nerve fibers that normally carry the sensation of pain can't work as effectively, okay? But this is such a basic, simple waveform that you don't need a big, complex machine. That's why there are all these little portable handheld TENS machines out there, which nowadays, I mean, it's almost like anybody can purchase one at the drugstore for like $50. Whether they work effectively or more effectively or not, I haven't seen any research to say that they do or they don't. But it's a very simple waveform. So, and it's pretty effective in reducing pain. It's almost like distracting the person from the pain so that they can perform activities. One of the things I always say about TENS is we don't put TENS on somebody and then say, okay, I took care of your pain, you can go away. And we'll talk a little bit later, but part of it is understanding what's causing the pain. And sometimes that is, weakness, or they have pain in a joint that if they can exercise that joint, that pain will reduce automatically or by itself. So a lot of times I'll put TENS on people and have them exercise while the TENS is on, increasing it or decreasing it depending upon the intensity of their pain, modulating that sometimes myself, not letting the machine do it because the machine will deliver it constantly at a set level. Sometimes you can put the TENS on for a while before treatment, and they will actually have a lasting effect. And that's because, again, go back to that synaptic junction, you've released all that neurotransmitter in the area, and it's clogging up that whole synaptic junction. Eventually, the enzymes will break that neurotransmitter down, and it will be reabsorbed into the, distal end of that synaptic junction, and allow the other neurotransmitter from the pain transmission to get through better. But because it takes a while for that to happen, you do get some lasting effect. So it's really nice to be able to do that for people before they, have some irritation so they can be more effective doing their treatment. And yes, sometimes I've done it at the end of treatment because what we've done has created more discomfort, and I want to kind of give them the time for their bodies to reset that pain level. So I will do this for them, not expecting it to have, permanent effect, but make it more comfortable for them, because if they just wait a half an hour, the pain level will naturally decrease on its own anyway. So let's give them a little comfort while they're waiting for that to occur. So there's also an asymmetrical biphasic version of TENS. Again, you're going to find it in the vector. It basically does the same thing, but it's not symmetrical in the waveform. And all I'm really going to say about that is you try one, you didn't get the desired effect, try the other one. Okay? It's nice to just have that variety. VMS is a muscle stimulation for creating muscle contraction. Again, it's in vector. It's a symmetrical biphasic waveform. Should be getting comfortable with hearing that now. It has a 100 microsecond interphase interval. Don't worry about that. Because it's pulsed, it's relatively short. The waveform has a low skin load. In other words, it has a low impedance. So it's suitable for doing high-intensity treatments like muscle strengthening protocols, like a Russian stim. As you can see in the title part, it's VMS TM, trademarked. So the Chattanooga group has trademarked this particular waveform, which in all honesty is very similar to a Russian wave, stim. But what all these companies do is they take a waveform and they alter it slightly, and then they can call it their own, and they'll trademark it. So this one is just trademarked. Works, nothing wrong with it. But you have Russian in the Transport 2 unit, and it will work usually just as well. Then they've also created a burst form of this form, which is just the same exact thing delivered in bursts. Boom, 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 that kind of a thing. And this microcurrent. Microcurrent's actually kind of nice. It simulates the natural electrical current that's generated by the body. So where this can really be helpful is doing wound care again, or trying to heal a structure, because it's sometimes overriding the odd electrical stim pattern that occurs in the body after an injury and trying to restore it to a natural function. Things respond, obviously, naturally to the body's natural current. Things like mitochondria, which are the powerhouse in the cells, so they produce more energy. There's more energy for the body to heal. So that's kind of the theory about how this stuff works. So microcurrent can work very well. It does not necessarily have to go on a wound. Sometimes microcurrent works really well on a trigger point to kind of get the natural, normal current flow restored. It can be applied through an electrode or a probe, and sometimes those probes are part of the machine. You'll see it. You plug it into a channel, and it's a little handheld probe. But I've also told people that you can use your own finger as a probe, and you can do that for a lot of these. You can do it for the muscle contraction, or you can do it for, well, I don't know if I do it for high volt. That might be uncomfortable for you. But I've done this to find trigger points or to directly treat trigger points. All you do is you put a 2-channel, like a pre-modulated, and you put the one electrode on the patient and one electrode on your, wrist, on the back of your hand, and you touch the patient. Usually I'll use a little like ultrasound gel to help with the transmission, and turn the current on, and now your finger has become the probe, and you can move that around to find, maybe specifically more trigger point areas and things like that. Try it sometime. DC current, you find it in the vector. They used to use it a lot. It's not used as much anymore. The one thing I'll say about DC current is that it will stimulate a de-innervated muscle. Okay? All these other ones will work on the neuromuscular junction or the nerve itself. DC current will work directly on the muscle tissue. It's very irritating because it's obviously direct current, which means you're pumping in all positive or all negative. And because those electrodes don't change at all, what you're doing is you're attracting negative or positive, depending upon which electrode it is, ions to the area. And I know when I said with the high volt, that's actually beneficial for a wound. In this particular situation, you can attract positively charged ions like hydrogen ions, and H plus creates acid. Or you can attract negative ions under the positive electrode, and OH minus electrons are what make up alkalis. And alkalis can sometimes be actually more irritating to the body than acids. Now, these are very, very mild in their form. It's not like you're going to suddenly create a little pool of hydrochloric acid, but they can irritate the skin. And a lot of times with direct current, you'll find a lot more redness underneath the electrode after the treatment is done. Now, that's all the electrical current type things that we have to talk about in here right now, but just a general point with all of them. And actually, when we get into, we'll talk about indications for use, and you'll see a lot of different things for using these. My personal feeling, again, is that I will never put a waveform or current or any type of electrical modality on a patient that I have not first put on myself. I want to know what it's going to feel like so I can describe that to the patient. If they're describing something totally out of the ordinary for my experience with it, I'm going to stop doing it and figure out what's going on with that. You should also have kind of a general idea of, well, what kind of intensity do I need to turn this up to under normal conditions to maybe create a muscle contraction. Now, again, don't get hung up on the number. I'm like, oh, I should only have to turn this up to 12. I don't know why I'm going up to 14 on you. It really does vary, but if you can create a muscle contraction, say, in the extensor mass of the forearm on yourself by turning the unit up to 12, and then you go and you apply it to a patient, and you put the electrodes relatively the same distance apart, and you're turning it up to 45, well, I would stop and say, okay, why do I need to turn that up so high? Is it the correct waveform? Are you doing it for somebody to work on the muscle reeducation post-stroke, and do you need to try a different waveform to make that happen? So keep all that in mind, and that way you have a relative idea of, I shouldn't have to turn it up this high to get the desired effect. Why am I cranking this up so high? Am I going to do damage to this patient? Is it a bad lead on your electrode? Okay, because that can happen, and you don't want that suddenly to kick in, and now you're delivering this overwhelming stimulation to this patient, okay? So indications for use. Just going to give you a basic idea of these things. For Russian, high volt pulse current, interferential, TENS, and premodulated, all of these will work on these ideas. So relaxation of muscle spasms, prevention or retardation of disuse atrophy, great for your post-stroke people or somebody even coming out of a cast. Increase local blood circulation. You can improve healing, not just of wounds, but even of a mostly healed and very stable fracture, because along with most fractures, there's also soft tissue damage that occurs. It may not be a compound fracture where it's poked through the skin, but underlying that, damage to tendons and fascia and all kinds of things. So you can increase local blood circulation to help heal that area. Certainly muscle reeducation. You can maintain or increase range of motion. That can be done through muscle reeducation. That can be done by increasing the blood circulation so there's more fluid elasticity in the area. That can be done through pain control. If it hurts to move that joint, well, decrease the pain and maybe they can move more. Contract, relax is a great option for some of these people who are contracted. Put the stim on, let it create a muscle contraction. When it kicks off, stretch them out. That kind of thing. If they're able to, have them contract when the stim is on so that they can actually relax when the stim comes off. Same thing for muscle spasm, you can do that. It's a great intervention. Immediate post-surgical stimulation of calf muscles to prevent venous thrombosis. Basically what you're doing is you're just helping to stimulate that normal muscle pumping action. put the stim on, make the muscles contract. You're actually squeezing the blood vessels, the venous system, so that it's going to return the blood out of the lower extremities, so that you'll have a lot less likely incidence of blood clot formation. So we talked about all of those types of things, but now looking at just interferential TENS and premodulated, these ones work great for, and it says symptomatic relief of chronic intractable pain. Will not cure pain, okay? But it can relieve a lot of the symptoms. I've actually done this with some success, not all the time, depends on the patient. But if somebody comes in with fibromyalgia and they've got this intractable pain going on, maybe up in their shoulder blade area, because it really doesn't work on that general sense of discomfort, because you can't put TENS on the entire body. But if you have an area that you can target with it, you may be able to decrease a lot of the pain for that area so that they can exercise. Fibromyalgia responds best to aerobic activity, actually. So some kind of, they need to move to make it better in the long run, but it can be very painful to get moving, and that's where this can really help. Post-traumatic and post-surgical acute pain. So, they work on acute pain as well as chronic. The post-surgical, of course, be careful. TENS or a low-level intensity, not creating muscle contraction is absolutely fine, but you got to be careful that you're not accidentally or inadvertently turning it up so high, because even TENS turned up high enough can create muscle contraction. You don't want to cause disruption to that healing surgical site. You can dehiss a wound. So, just that awareness. Person still has sutures in. I don't usually put TENS or even any kind of e-stim on them at that point. If they've had a dehissed wound, well, then maybe you can use some high volt current to increase blood flow, hopefully maybe heal that a little faster. But that's just, you check with the doctor on that. So contraindications, this is, there's a lot, but a lot of it is kind of pretty obvious. The first thing I'm going to say is if you have pain, don't do intervention of any kind unless you know why they have pain. And that's not just e-stim for me. That's almost anything. You may be able to figure out where the pain is coming from, and that's absolutely fine. I'm not saying they have to go to the doctor or you have to have a written explanation from the physician. But, if they walk into your clinic and the doctor gave them a prescription for therapy, a Allen treat kind of thing, and you look at them and, they've got some debility and they've got some balance issues and they got this and that going on. It's like, okay, pretty routine. And then they tell you that I have this intense pain in my low back on the, right underneath the rib cage on my back on the right side. And you say, oh, yeah, okay, well, I got some low back pain, so let's stick some TENS on there. Well, they could have a significant kidney infection, or they can have something else going on in that area that you kind of need to know about. Because if you put something on there and you start creating muscle contractions or increased blood flow to the area, one really bad scenario could be some form of bone cancer. And are you stimulating metastases by that? So, kind of just be aware of, well, what is the pain and why is there pain, so I know what to treat effectively or refer to a physician about. I mentioned cancerous lesions. That's point number 2. You don't do it over cancer. It says open wounds. Well, unless you're deliberately treating the wound, because you don't want to interfere with that wound healing process is what it comes down to. You could do TENS around the wound that's painful. There's actually no problem with that. But doing muscle contraction, those kinds of things over an open wound, you're just going to disrupt the wound healing process. Infectious diseases, because you don't want to increase blood flow and thereby spread the infectious disease throughout their body. You got to be careful, obviously, about your HIPAA precautions and all those things about transmitting, cross-contaminating to other people. So, if they're in a contact isolation room and you bring the eStim unit in there, you need to really clean that thing off before you bring it to somebody else who's not infected. Probably safer to not be doing it in the first place. Don't put the electrodes over the carotid sinus, the anterior neck, because that can disrupt the heart rate, or transferably. Certainly you don't do it through the head. Upper cervical spine, suboccipital, absolutely fine, but don't put one electrode back there and one on the forehead. Okay. There's been no safety established for doing something like TENS during pregnancy. I know of people who have done it. They try to avoid, obviously, medications and pain medications during pregnancy. There have been no problems, but, that's a really case-by-case basis and physician okay, because obstetricians have some of the highest malpractice rates in the country, and anything that goes wrong during delivery, they can get blamed for. So they may not let people do that. Typically, the ones that I've heard about it are actually therapists who said, I'm going to do this, and they sign off on it. Not someone who said, hey, can I get a therapist to come in and do TENS for me? Powered muscle stimulators on patients with cardiac demand pacemakers. So you don't want to be doing a lot of muscle stim for contraction when they have a cardiac demand pacemaker, because that can trigger the demand of the pacemaker and it will go off when it's not supposed to. Waveforms on patients with cardiac demand pacemakers. It says you shouldn't use any waveforms. That comes directly out of the manual for the machine, and I'm going to say that it's probably not a bad idea to pay attention to that, although have I done TENS on somebody's knee or ankle? Yes. But basically keep in mind, if somebody has a pacemaker, maybe we shouldn't be doing TENS or ultrasound, or eStim or ultrasound on them. So now, precautions for that, and again, these are precautions, things to be aware of, but don't necessarily mean you can't do it. If they have a heart problem, all right, are you going to overload the heart? Are you going to increase their blood flow and increase the preload on their heart, which, it's going to put more strain on the heart? Epilepsy. Are you going to trigger an epileptic seizure? Tendency to hemorrhage with the trauma or fracture. These are your really delicate people. Or, certainly they have the, bleeding disorders of any kind. Are you going to create a muscle contraction, microtrauma, and they're going to bleed? Surgical procedures when muscle contraction may disrupt the healing process. I mentioned that earlier. Over a menstruating or pregnant uterus. Here you go. Now, the last one said there's no safety that's been, talked about, and that's under the contraindications. But it said there's no safety talked about it, not you should not do this. So it's a matter of semantics. Here it's saying you need to be careful about it. And in this case, what I'm thinking more along the lines of is pregnant lady low back pain. I've done it. There's been no problems. I've always talked to the person significantly and educated them, let them know that there's no research that says that this has ever created any problems with the developing fetus. And I've had, pregnant ladies who say, no, I think this is fine, and other ones who said, I don't want to take the risk. Absolutely not. They understand this and, get their consent. I'm not saying they have to sign off on anything, but, just a little sense of, yeah, okay, I'd like to try it. Skin which lacks normal sensation. You'll see that one a couple of times. You need to be aware of it. Take a look, maybe after 5 minutes of running the treatment, turn it off, look underneath the electrodes. Is it causing irritation that because they have diabetic neuropathy, they didn't feel, and so they can't tell you it's a problem? So ultrasound. This one's a lot quicker than the electrical stimulation because it's just ultrasound. There's not multiple types. Ultrasound is delivered through what's called the piezoelectric effect. Basically, when you apply energy to a crystal, the crystal deforms. It doesn't mean that it changes shape. What happens is it creates oscillations within the crystal, which are vibrations. Those vibrations are then transmitted through the sound head as ultrasound waves. it's a sense works similar to your microwave oven, because what it's doing is it's vibrating molecules within the body, and that vibration as the molecules rub against each other cause heat. Microwaves do that with microwave radiation, and although it's kind of been said many times, microwaves do not heat from the inside out. They definitely heat from the outside in, because if anybody's heated anything up that's frozen, the outside may be hot and the middle is still frozen. And I won't go into the whole history of how it was developed as a microwave and called the radar range and all that kind of stuff. If anybody wants to know, you can let me know, and I'll be happy to share that with you. But this is why it's really important that we don't drop the sound head. And if it does happen, we should probably have it checked. And, you know, when patients sometimes feel a buzzing or certainly any kind of electrical discharge, almost like a static electricity coming out of it, you probably need to call the guy who comes in and calibrates the equipment and let him know specifically what's going on, because he'll just come in and he'll check it like they normally do and say it checks out fine, but he may need to be checking and there's a whole lot of terminology and physics behind the way that the ultrasound profile is coming out of the sound head, and I won't go into that detail because, quite honestly, I don't necessarily understand it that well myself. But if that's disrupted in any way or it's not grounded properly, you're going to get some of that irritation, and we shouldn't be doing that treatment, because then we don't know what kind of ultrasound waveform we're delivering to the patient. Indications for ultrasound: certainly relief of pain, muscle spasm, joint contractures, and those can be associated with adhesive capsulitis. Adhesive capsulitis, a lot of times I will do ultrasound while stretching. I'll put the person in a very mild stretched position, very easily tolerated, and then do ultrasound and heat up the tissue, the joint capsule, the ligaments that are involved. And then maybe after doing that for 5 minutes, I may try to stretch them a little bit further, do it again, and do it for a little longer, and then maybe stretch them a little bit longer. Bursitis with slight calcification, because ultrasound can break up some slight calcification. It won't break up a lot of calcification or hard calcification. It'll just reflect the sound waves the same way the bone will, and that can actually cause some irritation or subdermal burning. Myositis, soft tissue injuries, shortened tendons due to past injuries or scar tissue. It'll help just kind of elongate all those things. As you heat things up, they can stretch better. Relief of subchronic or chronic pain and joint contracture from things like capsular tightness or capsular scarring. So, you know, the ultrasound can do a lot of things that is pretty handy. If you'll notice, I will not talk about phonophoresis, and this borders on personal opinion, but there is research to back up the statement that doing phonophoresis is no more effective than rubbing cortisone cream on the skin. There's no difference in the depth of penetration, and it has no more lasting effect or any other effect other than just putting cortisone cream on the skin. So that's what I'm going to say about phonophoresis. Contraindication: this is going to look very similar to the ones from Easton. Don't do things unless you know what the problem is. Cancerous lesions, open wounds, and this just came up recently. There is an ultrasound technique for open wounds, but it's a particular type of ultrasound that I do not believe our units can achieve. And so while there is a CPT code for wound ultrasound, we don't have the mechanics to deliver that waveform. So I would say we do not do ultrasound for wounds. Infectious diseases, same type of thing. You can spread it. This gets really important when it comes to that cross-contamination. Even if a patient does not have any diagnosed illness or anything like that, whenever I'm done with the ultrasound, I clean off the sound head with a towel, and then I wipe it off with an alcohol wipe. And I will wipe it with an alcohol wipe and then not wipe that off. I will let it air dry so that it has contact time. It's so easy to transmit something from one patient to another in this regard because we use the same ultrasound head for all of our patients. We don't have different ultrasound heads for different patients because that's just way too expensive. We don't do this over bone growth centers because the bone growth, the epiphyseal plates, if they're not already fused, we can cause premature fusing. Now, we're not going to see that very much because that tends to be more in children and adolescents, which is not usually our patient population. But the same thing applies about, go down a couple to healing fractures. It's the same thing. We don't want to disrupt that healing fracture. We don't do it over the chest when they have a pacemaker because just like a microwave or a diathermy, you can actually affect the pacemaker or create enough heat to damage the pacemaker or the surrounding tissue. Certainly not over the eye. You know, some of these are really obvious. I wouldn't do it over a pregnant uterus. I don't see any reason to do that. Ischemic tissues with vascular disease, because what you're going to do with ultrasound is potentially increase the blood flow. And if you increase the blood flow in an area that it doesn't have the ability to handle, you're going to cause possible damage to the tissue. So just kind of be aware of where you're doing it. Precautions, again, these are not that you can't do it. You just need to be aware of it. Spinal cord after a laminectomy. Well, a laminectomy is a removal of a piece of bone. There is still bone healing that has to occur, so we need to be careful about that. Can you not do it? Well, you can do it, but how long ago was the laminectomy? 2 days ago? I probably wouldn't. 2 months ago? Yeah, you're probably okay. But, you know, look at the skin, look at the area, look at the individual. Are they a good healer? Are they a bad healer? Do they take more time to heal? Does the area look well healed? You know, then you're going to be okay. Anesthetic areas, you need to just be aware of that. Know that this person may not be feeling what you're doing, and if you have it turned up too high, you can cause burning. So just be aware of that. Hemorrhagic diathesis. I won't go into details. You probably never run into that. But, you know, be careful of bleeding tissues again. Now, big old danger one comes up. Really, you just need to be careful with anybody using any type of e-stim, ultrasound, diathermy, any of those things around somebody with an implanted neurostimulator or a defibrillator device. It can just cause a lot of problems, or you can actually turn the neurostimulator system off. Even if the neurostimulator system is off, you can affect it and stimulate something that you're not supposed to. So just be aware of those things, know those things, and just, these people shouldn't even be in the room while you're doing diathermy on somebody else. They should not be very close when you're doing ultrasound on somebody else. Probably safest to say the same type of precaution on that. Don't have them in the room while you're doing ultrasound. Additional precautions, there are potential for burns. I'm going to say this is pretty low. In my 17 years as a PT, I'm trying to think of a single instance that I even heard of a therapist creating a burn with ultrasound. I think, if anything, we are overly cautious about it because we hear about it and it gets drilled at us. The intensity has to be too high, too low a frequency, and we're going to talk about frequency in a minute because that is an important piece. Stationary technique, you're not moving the sound head. Moving the sound head too slowly. Obviously, the more that you're pushing into a small area, that vibration creating more and more heat, not giving a chance for that heat to dissipate by moving to another area and coming back to it, you can cause a burn. Lack of sensation for the area, so they can't tell you, hey, that's getting hot. And bony prominences, because there's just not enough tissue in the area to absorb the heat that you're generating. Again, talking about some of those things, sound head movement. I've been very bad in the past about trying to cover too much of an area at one time. I have done ultrasound on the entire paraspinals in one second, thinking I was doing something, which turns out I wasn't. They really talk about the amount of area that you can treat effectively with constant movement of the ultrasound head at continuous mode of delivery, really only being about 2 to 3 times the size of the sound head you're using. So you think about that, most of our sound heads are a 3 square centimeter sound head. And that means, you know, you look at the size of the sound head, and you put, you know, 2 more next to it. So that's the whole area that you can treat effectively, is what they're saying. And you need to keep moving within that area, okay? Otherwise, you're really generating enough heat. And to me, I think ultrasound is really a heating modality, because I don't see what else it's doing if you're not heating something up. And some literature supports that and some doesn't. So it's kind of a little bit more my personal opinion on it. So, but I use it as a heating modality. And if you're trying to cover too much of an area, you're not heating anything up effectively. So you need to keep the sound head moving. You have to look at the patient's susceptibility. Some people seem to be more sensitive to ultrasound. I've heard it from patients in the past where they've said, oh, I feel that. That feels weird. And I think, all right, they're crazy because you can't feel ultrasound, but you can. And, you know, it's interestingly enough that some people just are more sensitive to it. So pay attention to that, you know, understand that they may be feeling it. Output power. That's your intensity, how high you're turning it up. People like to know, turn it up to this. It does vary from patient to patient. It'll depend upon how hydrated they are. It'll depend upon your ultrasound gel you're using, not brand, but how much. So, you know, I kind of stay anywhere from 0.8 to up to a maximum of a 2.0, and that's in watts per centimeter squared. The smaller the area, or the more superficial the area, the lower that intensity. If I'm doing some deep, you know, this person's quadriceps, you know, over the real meaty part of the quadriceps, and they've got a pretty good sized leg, I may need to go up to 2 for that. You know, typically I'm around a 1 to a 1.5. But, you know, you got to say, are you getting the intended effect that you're trying to achieve? And from there, make an adjustment. Along those lines, you have 2 settings usually, a 1 watt and a 3 watt. And where that comes into play is how deep are you, how deep is the structure you're trying to influence, I suppose is the best way to say that. Thinking back to the waves again, like we talked about in E-stim, you have the horizontal line, and you have this wave that undulates above and below, that nice sinusoidal waveform. Well, if you look at a period of time, and, you know, I'm not going to give you numbers for it, just a period of time, and 1 megahertz is going to be, say, one of those waves in that period of time. 3 megahertz is going to be 3 waves in that same amount of time, okay? So we're looking at cycles per second again, but with a long, easygoing, undulating wave, you're going to be able to bypass a lot of structures very easily. With a wave that goes up and down much more frequently, there's going to be a lot more interference, and you're not going to be able to penetrate as deeply. So the lower the number, the deeper the penetration. And, you know, it sounds a little backwards, but that's the way it works. So a 1 megahertz is going to penetrate, you know, somewhere around 2.5 centimeters, where a 3 megahertz is really only going to penetrate about 1/2 to a centimeter. So keep that in mind. I mean, if you're doing a hand, there's not a whole lot of depth of penetration that you need there. If you're doing a low back or you're doing a thigh, you're going to need to penetrate deeper. The next thing on the list is coupling. and that is the measure of how effective are you passing the sound waves through a medium to where you want to deliver it. So in other words, your coupling is your gel, okay? So that's your ultrasound gel. First and foremost, don't heat your ultrasound gel. The hotter the temperature, the lower the coupling effect. So the warmer it is, and all those ultrasound gel warmers that are out there are really detrimental because they're heating the gel up, which is decreasing its ability to then transmit sound waves, okay? You don't need to put it in a refrigerator. Room temperature is fine. Of course, your patients are going to find that you put the gel on, it's cold. Let them know this is going to feel cold. And if they complain and ask why you can't heat it up, now you can tell them, because otherwise the ultrasound is not going to work as effectively. I think the Vector Genesis does, but I know that the Transport 2 actually has a warming feature for the sound head. That's fine, because having the sound head warm doesn't decrease the effectiveness of the gel. The gel is going to warm up during the treatment anyway because it's going to pick up the temperature, the body temperature. The sound head warming will probably speed that process up a little bit, but that will be a lot more comfortable for your patients. So it's okay to use the warming feature of the sound head. The other thing is putting too much gel. If you glob a whole lot of gel on there, you're dispersing the sound waves out through that whole mass of gel. You want to be able to put enough gel on so that you can slide the sound head very evenly, smoothly over the area of treatment without it kind of catching and rubbing, but not so much that you're pushing a large amount of gel around. Ultrasound is somewhat like electricity. It's going to transmit through the least resistive thing, and that's going to be the gel. And so you may be dispersing a lot of the sound waves throughout the gel. You're not penetrating into the patient. You're not going to get the right effect, okay? So documentation and billing, I thought it would be important to put this on the end just so that we do talk about this. Documentation, I did ultrasound today, is not enough. You need to include for ultrasound and for eStim, what body part are you treating? What settings did you use? So in other words, talk about the type. I did pre-modulated. I did 1 megahertz for ultrasound. The intensity, and I know I said don't get hung up on the intensity having to be the same all the time or slightly increasing, but put it down so that people know, okay, they're running this typically around 12 to 15, and then the next person comes in and they got to crank it up to 30, something's not right. Instead of saying, well, I don't know, maybe that's what they had it on last time, so I'll just leave it up that high. So document the intensity so somebody has a ballpark, but don't get hung up on having to achieve that the next visit. And the duration, how long did you provide that? You should also really include the skin condition after the treatment, and that sometimes means you have to let them sit for 15 minutes. Certain forms of eStim, certainly direct current if you're doing that, but even the high volt can create some redness, some erythema underneath the electrodes. That's perfectly normal. Does the erythema go away within 10 to 15 minutes? It should, okay? So you want to be able to say, when this patient left the clinic, there was no erythema present, because they could bump up against something on the way home, get a small skin burn, and the only thing they remember was that you did eStim, and then suddenly you're looking at a lawsuit. But they pull your documentation, skin check showed no erythema post-treatment, and you're covered. So when we bill, you bill eStim, you bill ultrasound as a service-based unit. You can't do ultrasound for 45 minutes and expect to bill 3 units. If you do ultrasound for 45 minutes, we need to talk because you're doing something not quite right. But this is a service-based unit, which means you get 1 unit of it a day, no matter how much you did. The 8-minute rule still applies. Okay, so you can't do ultrasound for 3 minutes and be able to bill a unit. But that being said, again, if you're doing ultrasound for 3 minutes, again, we need to talk because that's still not okay. But within this, it does include the setup time, the application time, because you have to be providing this intervention. This is a hands-on intervention, and the cleanup time. That doesn't include the time it takes to launder the, towels you used or transport the patient to and from their room. But, getting it set up, applying the gel, turning the machine on, doing the treatment, wiping the gel off, checking the skin, all of that stuff counts. So it's usually very easy to get at least 8 minutes because most ultrasound treatments should run for at least 8 minutes. Sometimes longer than that, depending on what you're doing. Again, think about what is it you're trying to treat, what are you trying to intervene with. If it's a very large area, you may have to do more treatment in order to provide enough energy to the area to achieve the desired results. Ultrasound, very simply, we use the code 97035, okay? eStim gets a little bit more tricky. Basically, we only get paid for the skilled time involved with eStim. So this is the time you are directly involved performing the eStim. So for a lot of times, that just means the time it takes you to set the patient up, turn the unit on, make the appropriate adjustments, maybe tweak it a little bit, turn it a little bit up if they're doing a 10s halfway through the treatment, or if they feel it fall off, you want to increase it back up again, and then the cleanup and the skin check time. Okay, not the time that they sit for 15 minutes to see if their erythema goes away, just the time that, you look and you say, well, it's a little redness, let's just make sure it goes away, and then you go back and check on them, yeah, it's gone away. That's the billable time for eStim. To be clear, the run time for eStim is not skilled and therefore not billable. And that's true for Part A and B. There is another company out there that provides some in-servicing to some of our facilities because we use their equipment, and they say something slightly different. But Legacy's position, reading the information that comes from Medicare, what they say is only the skilled intervention time for eStim is billable. We interpret that as runtime is not billable. So in other words, for a Part A patient, you can't put eStim on them, let it run for 30 minutes, and count 30 minutes towards their rug levels, okay? You may have 6, 8 minutes, whatever, between setting it up, adjusting it, turning it on, turning it off, skin check. That's what you put in your billable time, okay? There are also several different codes that can be used. So I say the most typical, the one that we should see billed most often, is the G0283, which is a service-based code, which means 1 unit. That's the supervised but unattended. Notice it says supervised. Because we don't get billed for, or we can't bill for the runtime, that doesn't mean you can go down to somebody's room with the unit, hook it all up, let it run for half an hour while you go down the hall to the gym and treat another patient. They should never be out of your sight because that's a safety concern. Now, you can put them in the gym in the corner while it's running while you're treating another patient, absolutely. And for that other patient, that's one-on-one treatment time because we're not billing for the time it's running. So we're not double billing on that, okay? But that's a supervised but unattended, meaning you're not hands-on. Occasionally, you may be able to bill the 97032, which is a time-based code. But that's a constant contact, hands-on application. If you're doing what I described before, the eStim through the tip of your finger as a probe, that's constant hands-on attendant. You're using your clinical skills to find the right area to be intervening on. If you're doing a contract-relax type of treatment where you have the eStim kicking on, contracting the muscle, and when it shuts off, you stretch, well, that's constant hands-on, and you could bill the 97032 for eStim, or you could bill Therex or even manual. You can't bill both because you can't bill two things for the same time. I would stress billing the manual therapy for that. It's just reimbursed at a better rate. It's also describing better the fact that you were hands-on with that person. In that instance, the eStim is like using a TheraBand. It's just a piece of equipment that helps you achieve what you want to achieve, okay? And there is also a wound care code, and there are slight differences there. I'm not going into a whole lot of the wound care, but this is, we have to be in a stage 3 or 4 wound, and again, it's a supervised, unattended, and service-based code. So that's it. That's the basic introduction. Hopefully you've gained something from this. I certainly hope you have. If you have any questions, please don't hesitate to contact me or the ARCs in your area, and look for another WebEx where there'll be more practical application of specifics for specific diagnoses. So thank you for attending, and I hope you take something away from this.